New ideas.
Big debates. Meeting the change makers.
Transforming services.
I'm Matthew Taylor, and this is Health on the Line, brought to you by the NHS Confederation. Today, a first for Health on the Line, although we hope it won't be a last. I'm delighted to welcome a member of the Department of Health's ministerial team. Lord Nick Markham was appointed Parliamentary Under-Secretary of State at the Department of Health and Social Care just over a year ago on the 22nd of September 2022. Nick's had extensive experience across the public, private and voluntary sectors. Amongst his many other roles, previously he was Lead Non-Executive Director at the Department of Work and Pensions and Lead Non-Executive Director at the Department of Housing and Local Government, and before that Deputy Leader of Westminster Council. Nick's also founder of Safe Haven, a social enterprise charity that provides homes for the homeless in London, which he is able to do through an innovative funding model which effectively securitises housing benefit. And then finally, last but not least, Nick's also got extensive private sector experience of roles including ITV Strategy Director, CFO at Laura Ashley and CEO of Top Up TV. But now, and this is why I'm interested in speaking to Nick, and particularly as Minister for the Lords, in the Lords responsible for NHS Capital, Land and Estates, Data and Technology and NHS Finance and lots of other things as well. But those are the issues I'm going to focus on. Welcome, Nick. Thanks for joining us.
Thanks for having me.
So I guess the first question is what have you learned? I mean, you've been in the role for 13 months. What have you learned in the role, about the NHS? What surprised you over the last year?
Yeah, as you could see from my background, I'm not a politician by trade. So, I've been doing various business stuff for the last 25, 30 years. I had obviously some links in terms of my non-exec roles to the departments you're mentioning. But it is an amazing thing where you go from being Joe Schmo off the street one day to literally the next day becoming a minister. And in this context, in terms of being in charge of the capital programme, you've got a 12 billion spend a year, which is obviously a major money. And so it's a steep learning curve. I mean, there's no other way to describe it. And I think first off, just trying to make sure that, I'd often ask the questions from the teams like that, do you really need a decision on this now? Because, I hate having to shoot from the hip. I'm very much dates driven in terms of my business background and everything. And so making sure that we're making good decisions, especially around capital programs where you are talking about long-term decisions. If we don't have to make a decision immediately, let's get the proper data and analysis about it. And so then in terms of lessons learned, I mean, the first thing again is that I think often the word national in National Health Service is quite a misnomer, in that I see a lot of very kind of individualised, separate trusts. And so a lot of what we're trying to do is, particularly in capital space, is bring it into one coherent programme. I know that we'll talk a lot more about the new hospital programme later on, but we had a system whereby every time we were building a hospital, we were designing a different hospital with a different approach. We got crazy numbers like, trivia question for you. How many different types of doors do you think we have in the NHS? I mean, the number is 27,000. Which really, wow. I don't, 27,000. I'm finding out, maybe next time I'm on, I'll be able to let you know how many different types of Lucy's we have. But basically what we have is a system of people developing things, with best of intentions instead of one uniform program. And so what I'm trying to do in terms of the capital program, and particularly around the new hostel program, is really just to try and develop a process of standardization, that we're using common parts, common designs, we're learning from best practice, so that we can, just like you do in any business, really try and understand what works well and then roll it out as widely as possible.
So the capital programme, the issues with the capital programme, there are a number of different sets of issues. One is obviously the quantum, and as you would expect me to say, running the organisation, running the Confed, we wish there was a lot more money available given the size of the capital backlog in the health service. Then there's a question of, well, who decides? How much is it centrally determined, the capital programme, and how much can be devolved, for example, to systems? And then there's the question that you've just focused on, Nick, which is okay, well, we know the quantum, we know where the decisions are made, but nevertheless, how do we spend that? How do we procure and spend that money effectively? I mean, what's the relationship between those issues? Because, of course, we tend to focus on the issue of the quantum, but you're focusing on the issue of how we get kind of value for money. Do you think that if we did things much better, it could make a difference to the fact that there isn't as much money as any of us might wish there was?
Yes, I mean the evidence of standardisation, and again, this isn't the DH in Department of Health won't be the first to do this. We've had a similar program going in things like prisons, and if you can go for a standardisation approach, then you start to get 20 to 25% savings. As you get the economies of scale going. So, again, just to give you an example, if you think about a patient room, bedroom. Normally, if it's not standardised and it's a different design, you will need a plaster, you need a plumber, you will need an electrician, you need someone to do the gas and air, you'll need someone to do the tiling. Whereas if you can have a standardised room, effectively you can construct that all off-site and just put it in as a module. Much, much cheaper, faster to build as well. So those are some of the things I'm talking about. Now, you're right, though, in terms of you've got to get the mix between allowing local systems to prioritise their capital spend and where to put it and where things are best done as part of a national programme. And, I'm definitely not saying that one size fits all will always be the case, but it's learning the difference between the two as a good way to, one, get the most bangs for your buck, as you say, but to actually make sure that, when you are building things, you're getting constructed as quickly as possible. Because I freely accept two things. One, we are spending more money than ever on a capital programme. It's about 12 billion a year. But at the same time, I'm very aware of just how much needs to be spent as well. And, the scale of the task that we're talking about, because the estate is massive. And these are things that unfortunately take a number of years to resolve.
Yes, absolutely. And what about the kind of the speed? I mean, the other issue that people raise is just how long it takes to get capital schemes approved. Could standardisation, do you think, help with that?
Yes, but also we've got our own approval process whereby, that takes far too long. So, it's one of these systems that probably over time is sensible. So, the trust might have their own sign-off process, then the NHS has, then the Department of Health has, then the Treasury has, and you put those all on top of each other. And, as I've tried to look at about how long it takes to build a new hospital, typically 11 years from start to finish. And we'll easily spend about 4 years of those in approval processes. So what I've tried to do as an example is, I found out that they have what's called a joint investment committee in the Department of Health with the NHS. And that would meet, 12 or 16 weeks before the decision came to me. So I said, well, look, I will quite happily sit on that joint investment committee. I value the comments anyway of the rest of the team on it all, and hopefully they value my comments, and we can take 12 to 16 weeks out of the timeline straight away and probably make better decisions. Same for hopefully Cabinet Office and Treasury colleagues in terms of involving them all in that loop together. So really trying to streamline that. But also, and then this is particularly pertinent to the RAC hospitals, we know that we've got to build those by 2030. We know we haven't got a choice. We know that if they're not built by then, we're having to decommission hospitals. So, especially the 5 new ones that come into this, if we take 3-4 years going through an approval process before we even start building, we're just not going to get there. So we have to streamline that process. That does candidly take some people outside their comfort zone because, sometimes you might be making decisions with less of the data there. But what I'm trying to do in all of this, and I say to them all the time, is look, you've got to weigh up the risks because you might be making decisions in the approval process with slightly less information. However, if we go on the status quo, these hospitals won't be delivered in time for 2030. So personally, I feel that there's a greater risk in terms of the approvals process and those delays now. There's a greater risk of being late rather than streamlining those decisions, saying that we don't need to do so many outline business cases, then strategic business cases, then final business cases. We can consolidate those So we get a much quicker approvals process.
Yeah, and that all sounds really sensible and to be welcome. But you've been in post for a year, and the issues of the state of the NHS estate go back, many, many years. But in the new hospital programme, particularly with the impact of RAC, there are hospitals that thought they were going to get a rebuild, a new hospital, significant investment, and who are not going to have that now for much longer. And you must have been around the estate, you must have seen the condition that some of these kind of hospitals are in, ones that will not now be rebuilt. How aware do you think folk in Whitehall in the Treasury, Number 10, are of the kind of urgency for capital investment in the health service?
I mean, it is difficult. I probably, in the last year, I don't know the exact number, probably visited 30, 40 different hospitals, just because it's only when you get around and see a place that you really understand the nature of what you're facing. And we know there are many, many examples where we need the work done. And clearly, we had to then suddenly prioritise, as you say, the RAC hospitals, and the Treasury, not unreasonably, were saying, well, that's fine. And to be fair to them and Cabinet Office and Number 10, they got in a heartbeat that we had to prioritise the RAC. So there was never any hesitation about putting them first. Their question always was, well, okay, then if you're putting them first, clearly others have got to be moved to the right. And how are you going to manage that process? And that's where I think one of the things which isn't written about a lot, but I think is a very positive development, is actually we've got agreement now of 5-year capital cycles. So effectively we've got from 2030 to 2035 now another 5-year cycle, and then 2035 to 40 another cycle, whereby those that had to be moved to the right in terms of us not being able to do it in this first phase to 2030 will come in the 2030 to 2035. And a general agreement, a bit like the Department for Transport has in terms of these 5-year capital planning cycles. This now is a long-term programme, which I think is a very welcome development. At the same time, I do recognise exactly what you were just saying, that there were some some places that they were hoping that they might have, be part of the new hospital programme to 2030, which now might be moved out to 2030 to 35 cycle, at which point that does mean that there's some investment that needs to be done now in terms of some shorter term work to make up the very worst affected parts of it all. And it comes back again to making sure we're very strict in terms of our prioritisation, understanding the situation there. I've said to all the team in the hospitals, understand exactly the nature of what we've got here, where there are critical risk items, make sure that we're on top of them. Not an easy situation. This issue is built up over decades, but something which hopefully a systematic program, bit by bit by bit over the years, we can really be seen to be getting on top of it.
And those changes that you've described, that move to that kind of 5-year cycle, we were at the Confederation, we kind of acted with the department as a secretariat for the Hewitt Review, and one of Hewitt's recommendations was a kind of review of the capital regime. So are there other changes which you're exploring which you think need to be made to the NHS's capital programme? I'm particularly interested in, given your private sector background, is there more that we can do to encourage a more entrepreneurial approach from systems and trusts about how it is they use their assets to be able to, I don't know whether it's disposal of land or whatever, ways in which they might be able to themselves be able to increase the investment they can make?
Absolutely. I mean, the one other part of my background, which she didn't put in the introduction, is I was used to be chair of London Continental Railways, which does all the regeneration rail stations. So we did King's Cross years ago. We did the Stratford Olympic site. We've got a huge project now in Manchester Mayfield. And actually, we made them into a top 10 house builder. A very, very simple program. If you think of any of those train stations that we're all very familiar with, you take the car park around them, you build a multi-storey on a third of the land, and you free up 2/3 of the land for housing. And you can put between 100 and 150 homes on that piece and desperately find land for housing. I'm very keen that we do something similar in we're using our hospital estates. We all know the challenges of recruiting staff and retaining staff, and housing can be a key help in that, particularly if you're asking people to move to a different part of the country to take up work at a hospital or even from overseas. Being able to give them accommodation so that they can get their feet under the table in a new job in a new place, I think is key in terms of recruitment and retention. And so what I've been working with our dealer colleagues in housing associations, a very simple thing about where we do have space on a hospital estate, we say to a local housing association, look, we will offer you the land at a peppercorn rent in return for you building there and giving us a nomination agreement so we can use it to put our key workers in. And also the fact, if I use an example, let's say that the construction cost of a house is 100,000 and the land value is 50,000, and we're giving them a peppercorn rent on land value, then they only need to get their return on the rent on the 100,000 rather than 150,000. So immediately that gives you a third discount, so to speak, on the rent that they need to charge. And the thing that's really valuable, going back particularly about the question, is that then that capital that comes out of the housing association's capital limits, not the hospitals. And we've got Treasury signed up to the principle of that, and we're actually doing a pilot program at the moment in North Bristol to absolutely prove the case. But there I see an opportunity where we've seen loads of hospital estates where they have got space on them, where if we can work with a housing association to put homes for our key workers on them using their capital, not ours, then that's a great way to create a win-win situation. I think there's similar examples on putting solar panel on roofs or using LED lighting, whereby the sorts of returns that you'll get there, you can easily finance from the private sector. So again, I think if we were to put solar panels on all our roofs, it costs us about £300 million, and we'd save, roughly 50 million a year. So you're getting a 15% plus type yield out of that, which again, candidly, with our limits, it might be hard to find 300 million out of our budget, but you can finance that with those sorts of returns and create a win-win situation.
Yeah, that's really interesting, and I think many of our members will be very interested in the possibilities that exist there. And of course, ICS's their fourth objective is around the NHS's kind of economic and social and environmental impact. So there's a kind of win-win there. Do you think, a more general point, do you think we underestimate the role that health investment has in economic regeneration? We tend to think about, there are bits of government that are around economic growth, and there are bits of government that are about spending, and health is in the latter category. But actually, in all sorts of ways, health investment can contribute to the economy, can't it?
Definitely. And I think there's a general understanding that we need to get upstream of the problems in terms of the prevention agenda. We know that hospitals often become almost a treatment place of the last resort because people will go to A&E at a lot of the time. Actually, they don't need to be at A&E, but they went there because, they felt that they couldn't get, a GP appointment, for instance, or they're fit to be discharged, the 13% or so, but they haven't been discharged because, we're trying to find social care places. So it is, as you say, a whole system program. And, that's why we see the ICS review as so important. And that does have, as you say, a much wider social and economic impact. I've seen fantastic examples. I was in Red Hill GP surgery the other day where they look at their so-called frequent flyers who are spending the most time, needing hospital treatment and saying, what can they do in terms of prevention to try and avoid that happening? And, I'm making a huge impact on that, which of course is better for them, better for their lifestyles, but as you say, better for the economy because those people can be far more productive. In terms of a capital initiative, we've got now these mobile lung cancer screening program whereby typically, unfortunately, we don't, something like 60% or so of people aren't detected with lung cancer until they're at stage 4 historically, and unfortunately then it's often too late. With these mobile screening centres that are going into the areas where that there's most need, we're now picking up something like 2/3 at stage 1 and 2 where you can treat it and you're fine. And obviously that's much better in terms of healthy outcomes, but that's also, of course, much better in terms of those people being able to return to the workforce and become productive members of the economy. So, that's where I see everything that you were working with Patricia on her review on, how you can create whole systems solutions. Completely agree with what we're trying to do there. And, it just has to be the direction of travel we're going.
Yeah, because it's interesting. It's a final question on capital, Nick, but it's interesting that whenever we talk about capital, you and I have been guilty of this ourselves in this conversation. We tend to just talk about hospitals, but actually a huge proportion of our primary estate isn't fit for purpose. I know that colleagues in mental health feel that mental health often is quite low down the list and the mental health estate's very poor. We want to move more investment into the community, into community settings, into health on the high street, for example. So, it is important, isn't it, when we talk about capital, that we're not just talking about hospitals, and also that we avoid the danger that we do sink an enormous amount of money into hospitals, and that actually reinforces a model of care that we're trying to get away from.
That's absolutely right. We all know the old saying that, it's the squeaky wheel that gets, the oil on it all. And that is a bit in terms of, the hospitals. They are obviously the most visible manifestation of the health service. And so naturally, in terms of all of our attention and spend, that's often where it goes. But it is those initiatives, either upstream or downstream. Again, on my many hospital visits, I found that in one of the hospitals, they just put in a physiotherapy space where they were then, as a matter of general practice, giving all patients over a certain age an hour or so physio a day. And in terms of their ability to then get home earlier and be fitter in there and needing less support, avoiding social care altogether, it just had a huge impact, absolutely massive. So, I think trying to look across the system, where we can get upstream of the problem or ease the problem downstream, that's got to be the way forward, as you say.
I want to turn now to digital and to technology. Now, your background as as a business leader, entrepreneur, you've been a digital pioneer. So, what's first of all, let's just start with your interpretation of why things are so difficult in the health service. I think almost everybody would agree that the pace of digital rollout has not been what we would want it to be. I guess the positive way to put it is that the cliche, the future is out there, but it's just very unevenly distributed in terms of good practice. Why do you think we are in the situation we're in?
I think we have, it seems the process I was talking about before, often about the capital spend, where you get layer and layer of approval and decision making. And I think generally we've got ourselves into a situation whereby we're more and more risk averse generally about making decisions. It's the old saying, no one ever got sacked by an IBM. And there's a lot of that where people just don't want to step out and run that risk. And so, you have all sorts of committees and consultants and processes, and it becomes very, very unwieldy. And we see situations where we know we can do it and do it quickly. Obviously, that happened a lot during COVID, but you've got situations like Joe Harrison, who runs Milton Keynes Hospital. He's a real pioneer. He's really passionate about digital. And you go there, and it's amazing, some of the things they've done there. Miles Scott in Maidstone, he's put in what I call a flight control system, which is looking at incoming ambulances and incoming demand. And you can see a projection on, there's like a flight control system where you can see that they know every bed in the hospital, and they can see if they've got an incoming, where those people are most likely to be ready to discharge them. And then if they are ready to discharge them, they've got a process in place immediately, which makes sure they've got their prescriptions ready, they've got transport ready, they've got porters ready to clean the bed and transport them. And it's all there through marginal gains. I call it like the Team Sky cycling approach, whereby it's just 1 or 2% gains in every little bit of process, but you put them all together and they're significant. And so as you say, there are those examples of those exemplars, but it's making sure that we can roll those out across the system. We've been trying to do that as really giving support from the centre. I think we've got some good examples of that. I think the electronic bed records and patient management, that is coming in absolutely, as you say. I think it is taking too long, but it is getting there. And the other thing I think which will make a massive difference in the theme of a lot we're talking about is actually trying to put looking at the solutions at an individual local level, we've got a series of big functionality enhancements to the app just coming up, which I think will make a huge difference. When you think about how our lives have changed in terms of banking and retail and media consumption with use of apps, your ability to make a GP appointment or your pharmacy first appointment, if that's the better solution for the condition you've got, being navigated to the right place in the first place, be reminded of that appointment on your calendar so you reduce the number of do not attends, be able to get your results on your phone and see your patient records so you can do your own type of research, and really take control of your own health in all of that. If you do need hospital treatment, being able to see what the waiting times are in a patient choice initiative, so you can see where can I get my treatment done in the quickest and most efficient. And for putting that sort of information and that sort of power in the hands of the user, the patient in this case, I think that's how we can really use technology to make massive differences.
That's interesting. And obviously, once again, and I'm not going to labour this point, but there is an issue about sustained investment. We have had kind of stop-start investment in digital infrastructure as well. But some of the work we've done, Nick, I'd be really interested in your perspective on this, has come up with what you might call, the innovation tragedy or the innovation dilemma. And that's this. And it doesn't just apply to digital, it applies to things like innovative medicines. And that is that in a sense, both our private sector partners and to an extent government officials and ministers want things to happen at scale. And if they're really going to make a difference, they do need to happen at scale. And the economics demands that action happens at scale. But yet what we find when we look at what works on the ground again and again and again is that the best solutions, the ones that have the most impact, are the ones that are designed very much around the particular local circumstances, local population. Clinical enthusiasm is absolutely critical to this. Sometimes the reason that national programs break down is that in the pilot you've got enthusiastic clinicians and then you roll it out to clinicians who aren't so enthusiastic. They've got other priorities. So do you have a kind of insight into how we manage this kind of innovation paradox that on the one hand we need to scale things up and on the other hand they've got to be designed to fit local circumstances?
No, you're absolutely right. And I think actually all we've talked about, that is one of the toughest things I've seen. I mean, the old joke goes that, the NHS have got more pilots than British Airways, but it's taking those pilots and scaling them up is the challenge. And we see local hospitals and right down to the clinician level who are quite fiercely independent. And that's where you have the problem in terms of the adoption. I think there are things that we're trying to do far more in the centre. I'm exaggerating slightly to make a point, but it's been the case in the past whereby we've had one place where, we've helped get that innovation going and it really works in one place, and then we say, we've proven the case, and then they say, well, great, how do I expand this? And we say, well, here's a telephone directory of 200 trusts. Good luck. Again, I'm exaggerating slightly to make a point, but effectively what we're trying to do now is actually put in place much more of a central buying setup whereby we are able to roll those products out according to that. And it's very interesting. I was actually in Boston just last week to try and absolutely learn some of the lessons that we see, because obviously Boston, you've got a fantastic ecosystem of the Harvards and the MITs of the world, and then the top hospitals in terms of the Mass Generals and the Boston Children's Hospital, and the entrepreneurial flair and venture capital, where they really try and foster innovation, and then the scale out and roll out from there, and what we can learn from that. And a lot of it, I think we are very good at the innovation. I think we can do some more to foster some of those partnerships between the clinicians and the hospitals and teaching hospitals and sometimes the local venture capital partners. But actually the scale out and adoption across the system is the real challenge. We've got some good examples that we're starting to get now, where we've got things such as the AI delivery platform, where you've got things like Brainomics, which is really improving the stroke treatment, and we're getting platforms where we can effectively roll those out across the board. So there are bits we're doing there, but I would say of everything we've talked about, that's the one now that I'm really trying to focus on to improve, because that is quite a challenge.
Yeah, we're in conversation with a leading university that would bring other universities to the table, and also commercial partners, to think about whether we can create a kind of capacity between our members, academia, commercial sectors, to think about this rollout challenge and how it is we can help to spread innovation more effectively. So maybe that's a future conversation for us.
Yes, love that.
Couple of kind of final questions. I know we're going to be careful because of the commercial sensitivities here, but tell me what your hopes are for the National Federated Data Platform. How do you think that's going to turn the dial?
Well, and again, I don't know if you've seen, I'm sure you probably have, some of the things that Chelsea and Westminster in particular have been doing in this space. And whenever they show it to me, in some ways, the great news is it's so simple. The slightly frustrating thing is it's so simple. Why haven't we done this before? If you know what I mean, in terms of, they show me what they do and say, well, look, these are all our patients here, and this is what this person is suffering from, and this is what we're going to do, and we're going to book them into this slot, and we're going to immediately have the follow-up action, and the appointments get fixed, and the communication goes out, and this is how we keep track of it all, and now we're going to book them into the theatre, and this is how we get the utilisation. And, you just see it, and it's just like, oh, that's great, but this is, pretty darn simple. But then they talk about what happened before, where they had spreadsheets and bits of paper, and you could just see how these things got lost. So at the basic level, I'm just amazed by the simplicity of just having all the information in one place, and just the ability to make sure that people are captured. You knew exactly what needed to be done. As I say, you book your points from there, and it gets followed right the way through. And, Chelsea and Westminster were able to talk about how they'd increased utilisation of their theatres by 20-30%, how they actually found that as they went through this process, they cleaned up a lot of the database where they saw that actually there were duplications or people that didn't need treatments anymore. So I think that can really make a massive difference on their whole waiting list and electives. And then you've got other examples of other hospitals that have used it to really get a quicker discharge out, and so really reduce the so-called bed blocking from it all. So what I see most of all is that, and this is what I see very much the job of the centre, is that, we provide the platforms. So we provide this federated data platform from which clinicians and hospitals will develop the innovation. And so that discharge model that I was talking about, that was developed, I think it was Stoke Hospital, apologies if I've got that wrong, but that was developed by one of the local hospitals using that platform data. As I say, Chelsea and Westminster really forged forward from that. So it's giving that platform common data from which people will then be able to develop the services. And this is where, amongst all the challenges that we know we have, where I see, the real grounds for optimism. Again, when I was in Boston just last week, they were saying, look, you don't realise the power that you have in terms of your data. There was one company there that had raised $250 million to invest in using 9 million hospital records of just a single health system. And, just the hospital records. And they said, look, you've got 50 million patient records, and not just secondary care, but primary care as well. And you can link them all together through the NHS number. Yes, it will be messy linking them all together. We're not saying it's easy in terms of cleaning up the data. But then they were saying, look, think of dementia as an example. Our problem about dementia is that we are really shooting in the dark in terms of the cures. When we know what we're going after, like we did with COVID, we were able to target something very, very quickly. The trouble about dementia is we don't really know the causes. But when you think about your data and the fact it's longitudinal, you can take people who are suffering from dementia when they're, 75, 80, and look back at their GP records when they're in their 50s and 60s and see, are there linkages through all that AI, and they will come up with patterns that we just haven't seen. To see, are there some early warning signs that we can then really set our researchers going after. So to me, that's, our whole data platforms, that's exciting in terms of just the basic management of patients through the in navigating through the health system, but B, just being able to use them to really pioneer new areas of research and development.
Well, Nick, we're really grateful to you for giving so much time to us. And I'm just going to ask you one final question before I let you go back to your ministerial duties. And that, you've talked a lot about a kind of incremental, agile approach to change. And I always think that there are two things we have to do together, which involve different kinds of ways of thinking. One is that we need to try to think like a whole system, because our health system is complex and interrelated. And if you try to achieve change in one part, you need to think about what the ramifications are across the whole system. So you need to reimagine the system, but then you need to adopt it exactly as you've said, this very kind of entrepreneurial, agile approach to change, because the world is unpredictable. Change is unpredictable. But just in that, if I was to say to you, just give me one or two thoughts about the health service of, I don't know, they might be there in, say, 15, 20 years. What do you think are the things that are most fundamentally going to change about health over the next generation?
So I really think it will be the use of, firstly, the people using the app to navigate their whole approach and taking control of their health. And again, being able to show, because the data will exist there, and they will be able to look at my background, look at my DNA background, look at my patient records, look at my lifestyle factors, how much I'm drinking, whether I'm smoking, what I'm eating, and be able to start to prescribe my own individualized screening program and course of action. Now, a lot of the time people won't take that up, and that's their choice. But a lot of the time, you give those people the pointers, and I think you would just see, I think we're seeing a shift away from a health system which, 40, 50 years ago, there was very much the doctor knows best. And when there was something wrong, you would turn up the doctor, you were told what treatment you needed for a cure, and off you went. To actually very much, much more active management of our own health, where we know more about our own bodies and our health, backed up by having the technology to kind of support us in that. And we're taking a much more active participation in our health in terms of prevention, early diagnosis and treatment. And armed with that, I think that will fundamentally change the way that health is set up to support around it, rather than being based around hospitals and treatment, very much around the care of the whole patient. I think that's the journey that we're going on. And that's where I have to say, as a minister, sometimes some very, very hard moments. This is by far the hardest thing I've done in my life, where it really is difficult in terms of all the challenges you're trying to face. When you see those kind of the sunny uplands, so to speak, that sort of healthcare for the future, I think is, that's the sort of thing that gets me out of bed in the morning. And I hope that we look back in 15, 20 years and say that the investments we're putting now in terms of, the app and the digital platform and technology, as well as the new hospital program, I hope that we're really setting the foundations down for what will be that future.
Well, it's great to end on a hopeful note. So, Nick, thanks for the work that you do as a health minister, and thanks so much for joining us on Health on the Line. Well, thanks for listening to Health on the Line, and do listen out for future episodes. And if you enjoyed the programme, please just take 5 seconds to leave a rating, or a few more seconds to leave a review on your podcast platform. It really does help to get more people to listen. Have a good week.